Dear colleagues, nowadays most of us do Phaco under topical, and very often we encounter an uncooperative patient. In such cases, I hold the sclera with a tooth forceps, just push it to the limbus and make all the incisions. The main incisions as well as the side port incisions. While I keep holding the incision on the right side as well as on the left side, the stab incisions are made with my right hand. It is possible. Now we can see that this is a mature non-intumescent cataract, and I am going to stain the anterior capsule of the cataract with trypan blue dye, and I always stain the capsule underneath an air bubble, and I wash the dye out immediately within 5 seconds. Now after this, I inject 2% HPMC, hydroxypropyl methyl cellulose. These steps can be managed when the patient is moving the eyeball, but two important steps: making the incisions, number 1, and number 2 is while I do capsulorhexis, I must fix the eyeball. I take a stout tooth forceps. Here it is. I hold it, just push it to the limbus firmly, and I do rhexis. Incise the capsule, raise a flap, hold the flap with ureter forceps, and since the patient is uncooperative, I cannot keep focus all the time, but still we can make out that I am comfortable with doing rhexis when the eyeball is fixed with my left hand. Rhexis is done. Now I can release the hold, and I do hydrodissection. When the patient is moving his eyeball, it is possible to do hydrodissection. So Phaco under topical, those who are still not comfortable, Phaco under topical is possible, and one of my colleagues taught me that, Pradip, it is just a mental barrier. Just once you think that it is nothing, it is easy, it is possible, then you break that barrier. And once you break your mental barrier, whatever you have thought tough, difficult, so long becomes so easy. This is a grade 3+ cataract, and it is easy to do direct chop in such cases. These steps are easy. The first thing is to break the barrier. While the patient is moving his eyeball so much, how can I do all the steps? And once two instruments are inside, the Phaco handpiece and the chopper, you can fix the eyeball. You are more stronger than the strength of the eyeball, and you can manage the steps quite comfortably. At this time, this is Oatley's Phaco machine, Cataracts 3. At this time, the Phaco power was 70%, flow rate was 45 ml per minute, and vacuum was 450. And this is the last fragment. This density of cataract is ideal for the beginners who want to shift from divide and conquer to direct chop. It's not very hard, not very soft. Maybe a little less denser is also okay. Now I have removed the chopper and emulsified the last bit of nucleus with only the tip of the phaco handpiece. And sometimes we will notice that the patient who was moving his eyeball very frequently at the beginning moves less after 3 or 4 minutes are passed. Patient becomes accustomed to the light probably, and once you keep telling him, he starts to cooperate. We are cleaning the cortical matter. Whatever instrument you are comfortable with, you must do the step with that instrument. If you are comfortable with bimanual IA, it's fine. The idea is to clean the cortical matter nicely, to polish the posterior capsule nicely. Whatever instrument you are using is okay. Choice of instrument is surgeon's, and what step is to be done is cleaning that's the most important thing. This scholastic substance has been injected, and here goes the intraocular lens. The leading haptic goes into the capsular bag, and the trailing haptic is guided by the chopper into the capsular bag. This is a hydrophobic single piece intraocular lens, sensor 1. Now viscoelastic substance is thoroughly cleaned. I go behind the IOL and irrigate the space between the lens and the posterior capsule. I do bimanual IA. Thorough cleaning of viscoelastic substance is required. And now this is moxifloxacin. I give a moxi lavage, inject it here now, and at the end I will wash it out. You may say it is just like not injecting moxifloxacin, but what I believe is, when we inject something inside the eye along with antibiotic, something else also can enter into the eye. So I give a final wash, thorough final wash under higher magnification, form the antechamber with fresh BSS that is coming from the bottle, and then conclude the surgery. Here it is. This is completion of surgery. You can see that wound is very nice. Thank you very much for your attention. Hope this video will be useful in your practice.